proceed ahead. So, guys, for the long case, 95% of you will get this CM's commerce as a long case. So I sincerely believe that next 45-50 minutes, just pay attention. You would have all practiced it a number of times. For them, it will be a revision. And for the people who are like, jinke यहाँ पे academics were not being held regularly, so this should be the one of the thrust motive for you. So for the CM's commerce, one is the entire way where you give the whole history, whole examination, and then you move on to the Viva finding. And secondly is when the day just passes off, starting 2-3 students give their Viva. So then sometimes what happens, that examiner might ask you, okay, doctor, give me what are the positive findings, and from here your Viva may start. Okay, so our main target will be to reach Viva. So for reaching the Viva, some quintessential things for the history are required. Similarly, some things for the examination purpose is required. Okay, so we, after climbing these steps, we'll reach till what all will be the Viva questions. So for today, basically, we'll start with the history taking part, and let's see how far till we go about. And the scheme of going ahead will be it's just like a case presentation, and what all questions can be asked from that particular thing, that also we'll see it along with, like what all questions will be there, and what all things you have to answer for that. Okay, so let's start with it. My patient, time taken around 45 to 50 minutes for today. Okay, so my patient, Mrs. XYZ, 40-year-old female, occupation if any, resident of whatever place, presented with. Now, what are the chief complaints that you have to give over here? Like obviously for CM's commerce, start with the important findings. Discharge should be the most important thing that you have to start with. Please don't trouble yourself with otalgia, with tinnitus, with vertigo. ठीक है, Viva starts with whatever we utter. ठीक है, Viva starts with whatever we utter. So आपने tinnitus बोल दिया starting में, and your Viva, if it goes on tinnitus, so फिर चीजें मुश्किल होंगी. So our work should be to make things easier for us. So speak those things which invite open questions, जिनके answer you would have already read multiple number of times. Okay, so let's start with the patient presented with complaints of discharge from supposedly left ear, or itna duration, 1 year, 2 year, 3 years, since childhood, whatever you want to go ahead. इसके अलावा what all features can be coming? It can be hearing loss, it can be there. Check. So apart from discharge, what all can be there? Hearing loss can be there. Otalgia can be there. Tinnitus can be there. Vertigo can be there. Oral fullness can be there. But I sincerely suggest, this I followed entirely during my residency, and post that I am always advised, don't mix up with these things. Why? We'll just see how to go about it. Okay, so Dr. whenever you get your case, 99% assured it will be squamous only. It, like mucosal नहीं मिलता अपने को एग्जाम में, है ना? So we should be aware about what discharge we are talking about. ठीक है? So how? We should be aware about what is the discharge that we are talking about. So after this, we'll be going in the format of long case only. Okay, so going about the HOPI. Okay, so the HOPI, the discharge is insidious in onset. And now comes the important parts from where you will invite the questions. Okay, why? Okay, sir, the discharge is continuous, purulent, foul smelling, blood stain. We all remember that these are the classical characteristics for the discharge of squamous. Now, यहाँ जैसे ही आप बोलेंगे, just look at the examiner, and the favorite question comes for the from the examiner, that why do you say the discharge is continuous? Why the discharge is foul smelling? Why the discharge is blood stain? Can somebody help me with answers? Anyone? Why the discharge is continuous?
So, continuous osteolytic process happening because of the disease?
Exactly. Because Cm squamous is a continuous relentless disease, and there will be osteitis जिसकी वजह से the discharge becomes it is continuous. Okay. Then it is purulent because of the putrefaction and the separation of the bacteria which can be present. Similar thing explanation for the foul smelling. Now, why the discharge is scanty? यहाँ पे अगला question will come this thing. This is scanty over here versus
due to lack of goblet cells.
Exactly. This is profuse. जो mucosal का the discharge of mucosal, that is generally profuse. The patient will say that the discharge is like it's dribbling out of the ear, and by the time she wakes up, it might have stained the pillow also. These are also the history, but generally in squamous it is scanty. So why it's scanty? Because the discharge is generally because of the shed epithelium of the debris which is there. है ना? There is no involvement of the mucosa. यहाँ पे mucosal में what happens? What is the disease pathology in mucosal? There are goblet cells in the middle ear, which basically they keep on secreting the mucosa. For rhetorically, it keeps on gobbling out lots and lots of mucus out of the ear, and because of that it becomes profuse. Okay. Now there's one more question. There are few reasons where there are few scenarios when the Cm squamous the discharge might become profuse. कब हो सकता है? दो चीजें आपको पता, you should be remembering. One is when there is a perforation of the tympanic membrane. It can happen because there might be coexistent mucosal disease along with the squamous. And when the cholesteatoma sac breaks open into the middle ear or the mastoid. Basically, you also develop a mucosal pathology apart from the squamous thing. Okay, so remember these are very favorite questions, and definitely you are gonna be asked this question in your exam. And please wait for these questions as you go ahead. Okay. Second. So this you have mentioned, discharge. Now, any aggravating or relieving factor for the discharge? Aggravating or relieving factors for discharge. What can be the aggravating or relieving factors? This can be due to the URTI. Okay, and there might be use of topical ear drops, which will be the relieving factors. Okay. Mention all the subheads of the history as we have learned from our UG days. कोई section should not be missed when you are presenting a long case. Okay. So apart from the discharge, second thing supposedly hearing loss. Second problem is hearing loss, which generally people present with. Okay, so sir, there is she also complains of decreased hearing in the left ear since 1 year. She also complains of decreased hearing in the left ear since 1 year. And this is, how is it? This is insidious onset, progressive, non-progressive, whatever you want to answer. And you can also to help to explain the extent of problem, you can also say that she uses mobile phone with the other ear, that is the right ear. So this will help you in putting history that the severity is such that she is using phone from the other ear, not able to use it. There is no history of otalgia, tinnitus, vertigo, oral fullness. So यहाँ पे एक बहुत favorite question generally people ask, something called as fluctuating hearing loss. So So this is a very likely question for the part of this hearing loss. So can somebody help me? What are the causes of fluctuating hearing loss? At least 3. Aji Doctor Sahab, at least 2, at least 1.
Labyrinthitis.
Labyrinthitis में fluctuating hearing loss will not be there.
OME.
OME, yes, Doctor Sahab, absolutely correct. Anything else?
Yes, sir. Carotid dissection. Meniere's disease.
Meniere's disease. 2 टिक हो गए. कैरोटिड डिसेक्शन में मतलब कैरोटिड डिसेक्शन में कैसे आएगा फ्लक्चुएटिंग लॉस? मतलब आई हैव नॉट रेड अबाउट इट. ठीक है. सो द आंसर व्हिच द बुक्स गिव है ना, which is present a minute please. बंद करो. Thank you. Which the books give. First is OME because it's the common part. Second is your Meniere's disease. Third will be your perilymphatic fistula. ठीक है. This perilymphatic fistula is a very important question from your exam point of view. Please mark it again and again. ठीक है. Not only for this fluctuating hearing loss. What is the principle behind this fistula? What is fistula sign? How do you elicit it? Blah blah blah. We'll see it multiple number of times. But जहाँ भी पढ़ोगे fistula, just earmark it. It will come in always. And apart from that, any serum with active discharge. Okay, so my suggestion will be the sequence should be the same. Just don't start with Meniere's disease because what I have seen, the importance which is being given to Meniere's disease, it's very important. Clinically, very few number of cases. Like for me, during my residency, I hardly saw 2 cases, which were already diagnosed and everything was done. So Meniere's disease को थोड़ा नीचे रखना है preference पे. OME, well, very good. Perilymphatic fistula, Meniere's disease, and COM with active disease. This is a very important question. Please ratify it. It is important. Now comes the most important part for your history taking. That is the negative history. Why it is important? I'll just help you out. Sir, there is no history of fever. और जैसे आप fever बोलोगे, the question will come. What is the importance of fever? So can somebody help me? Why fever is important? या COM में fever कहाँ पे आएगा?
Meningitis, intracranial complications.
Exactly, Doctor Sahab. तो intracranial complications में आपका meningitis is very important. ठीक है. If you speak meningitis, you might be asked what is your Brzezinski sign, Kernick sign. Be ready with it. Any more things for fever? कहीं और fever आता है किसी और complication में?
Thrombophlebitis.
Yes, Doctor Sahab. Absolutely correct. So second question will be lateral sinus thrombophlebitis. Now, यहाँ पे अगला question. What is the name of the fever which is given in the lateral sinus thrombophlebitis? It is called as yes, Doctor Sahab. It is called as picket fence fever, and they might also ask you what is picket fence. So read about it. This thing. This is the pathology behind it. Read it. And fourth question which can come from here also, which is OSCE in itself. There is a delta sign seen in your lateral sinus thrombophlebitis. This is a OSCE question. ठीक है. तो ये 4 चीजें आपको पता होना चाहिए from this section. Okay. Apart from that, brain abscess. We have not seen any brain abscess like owing to the use of antibiotics and all. But it is an important question. I presented a case like in the NBEMS forum during my residency. I think I was in second year में रहूँगा. So this was a question which was asked from this NBEMS faculty, like what are the stages of brain abscess? Like I was not aware, पढ़ा नहीं था. So this is what they told कि मतलब since you guys are from the antibiotics era, you would not have seen these cases, but during their time they were like very common. So please read about the stages of brain abscess. Okay, so let us move ahead. यहाँ पे ही please, if you people have not read Shambog, please read the complication part from this book. Complications of COM. ठीक है. Please make it a point. There are few things from few books जो आपको आना चाहिए. Shambog से complications of COM, it's hardly 5-6 pages affair is there. Please go through it. If you don't have the book, please let me know. मेरे पास पुराना वाला होगा. I'll share it with you. But go through it. It is important. Worth reading it. ठीक है? Moving ahead. Sir, there is no history of fever. Apart from that, sir, there is no history of swelling behind the ear. See, I am openly telling the examiner कि ask me, why did you ask about swelling behind the ear? See, if you will give examiner the hints, he'll ask you a question and you will get the more marks. If the examiner doesn't ask you a question, or if he asks from his own knowledge, so we will not be able to match the knowledge of examiner. है ना? He is a senior chap, 30-40 years of experience, so he might ask anything. ठीक है? So give him this point कि अच्छा, why were you asking about swelling behind the ear? Sir, we were thinking about any abscess over there, any swelling can be there. So, achha, what are the abscesses that you know about? And जैसे ही he says what are the abscesses you know about, you just blurt about Bizold's abscess, Luke's abscess, Siteli's abscess. You have read about it. So, putting the questions over here, please read about Bizold's abscess. Siteli's abscess. ठीक है? Again, Shambok. ठीक है? Best given in Shambok. बाकी आपने, if you have made your notes, please go through it. That's also important. So there is no history of any facial asymmetry. Okay, so like truly involving that for the complications of CO, facial nerve can get involved and hence leading to facial nerve palsy. Okay, so anybody knows about two scales of facial nerve palsy? First is your House Brackman. ठीक है, तो House Brackman के अलावा anyone more?
Sunderland class.
Sunderland is the for nerve trauma to nerve degeneration regeneration. उधर पहुंच जाएंगे. Something related to Sunny. Sunny Brook. ठीक है, from the Scott Brown facial nerve का जो chapter है, go through it. Sunny Brook scale. Nothing, don't go into detail. Just name you should be aware. Okay. So after the negative history, so you can also mention about. Sir, there is no history of any trauma to ear for traumatic perforation, any head injury for similar reasons, exposure to loud noise, or any consumption of ototoxic drugs. Sir, there is no history of nose, throat complaints. So, यहाँ पे आपका negative history, you have covered everything from your HOPI. Then go for the past history. Sir, there are no history of similar complaints in the past. No known chronic illnesses. So what are chronic illnesses you should be worried about in your patient? This can come as a question. So easier way. So diabetes, why? Sir, this has poorer recovery rate. Patient can go like for the malignant otitis externa, all those things can come. Similarly goes for your tuberculosis and any other viral illnesses. So there is no history of any surgery on the ear. We should be aware about what all things is happening to the patient. So after past history, please mention all the points. If the examiner has told you present, go ahead with the case. So all the points of the history should be covered. Okay, it should be not like sir, I thought it's not important. Haji, doctor.
Sir, just have a question. So, in case the examiner says that you had mentioned in your history that that the patient got relieved after using this ear drops, right? So they say that that, don't you think that the ear drops is an ototoxic, like if they're using too much of ciprofloxacin and gentamicin drops and all that. So in case they catch on that.
So that's why you should not give hints to the examiner. Like, see, supposedly if I were in this situation, I'll say this, there is no relief after using the eardrops also. So what does it indicate? Like example, if it is squamous will not get relieved now after using eardrops also. Mucosal will get relieved after using eardrops. Okay, so you should give your history should be like such that you are telling examiner कि हाँ it is commerce only. वहाँ पे don't leave like कि question mark वहाँ पे नहीं छोड़ना है कि like उधर पे आप बोल रहे हैं कि sir patient is using ear drops. Okay, see, ultimately it's up to him whatever he wants to use, but it's up to you what you want to tell the examiner. है ना? So my suggestion is कि utter those points only that you will be able to defend properly. Okay.
Okay, sir. Okay.
Going ahead, personal history. ठीक है, पर्सनल हिस्ट्री में अगेन सिमिलरली व्हाट वी यूज्ड टू सी, कंज्यूम्स वेज नॉन वेज मिक्स्ड डाइट. ठीक है, यहाँ पे इंपॉर्टेंस इज फॉर द नो हिस्ट्री ऑफ स्मोकिंग और एल्कोहल. नो डॉक्टर साहब, एनी इंपॉर्टेंस फॉर दिस? Yes, sir. Smoking is important. Why smoking is important? During the evaluation examination thing, we will see Mary's index. We will see about Mary's index. So what is Mary's index? Anybody? For what it is used? Middle ear risk index.
Risk index.
It has multiple parameters over there. है ना? One parameter is smoking. Now what does this Mary's index indicate? किस लिए करते हैं Mary's index? क्या बता? What does it tells us?
Outcomes.
Exactly, Dr. Sab, है ना? So जब आप वाइवा में when you reach the वाइवा, he might ask, one question will be there कि अच्छा डॉक्टर साहब, there are you have so many like 2-3 patients of the same problem. How like for do you have anything with which you can assess कि इसका outcome कैसा होगा and the next patient how will be his outcome? Yes, sir, we have Mary's index. So from there, your Viva will go on to Mary's index. Like as a resident, I had rectified this Mary's index. I know it's a boring job, but for exam purpose, you will have to do all these nonsense things. So when you go for the exam, जब आप examination पढ़ेंगे, examination में mention कि sir the Mary's index is so and so, and let him ask, अच्छा okay, what is this Mary's index? And you blurt out talk for the next 2 minutes. Don't stop. Let him feel कि हाँ ये पढ़ के आया बोल करके. ठीक है. So read about Mary's index. It's an important OSCE question also. And where you will read about Mary's index from Scott Brown, there are 2 more scale used for the same purpose, OOPS and SPIDE. Okay, please read about them also. Only name and full form is important. Okay, so you will tell about bowel bladder and sleep cycle. Nothing, no more fun over here. Okay, smoking is important. Smoking को याद रखना. Then after personal history, you will be family history. ठीक है, family में sir there is no history of similar complaints in the family, no history of allergy in the family. Allergy is important because this might lead to allergic rhinitis, CRS, and then ultimately your registration tube dysfunction and bilateral obstruction में the people who have bilateral cm, for them you have, there is a dictum, no? People having the bilateral cm, you will do a nasal endoscopy. This is for this reason. Any mass in the nasopharynx, any allergy or something like that. Okay, then you have to mention the treatment history. Yes, sir, there is a history of using over-the-counter drugs that you can mention over-the-counter this. And then any history of any surgery in the ear, nose or throat. Then उसके बाद आता है आपका summary. Now take a minute, okay, take a minute and just try to summarize in your mind कि जब आप examiner के सामने बैठे होंगे, you will be sitting in front of the examiner, how you will summarize the case. Believe me, once you get this case in your exam, you will definitely get it. है ना? Practice once or twice how you are gonna speak in front of the examiner. Your confident 4 lines of summary makes a huge impact on the examiner. Okay, but if you get stuck, like I'll tell you after 1 minute when we start with the summary. If you keep getting stuck everywhere and examiner is prompting you, Dr. Sab this, Dr. Sab that, so that is not very good sign. Okay, just take a minute and summarize in your mind how will you go about it. ठीक, आई होप थोड़ा थोड़ा किया होगा. ठीक है कि सर 40-year-old female patient without any comorbidity came with complaints of otorrhea from right ear or left ear since 1 year duration and hearing loss from the left ear. The discharge is continuous, scanty, thick, foul smelling and bloodstain and associated with hearing loss since 1 year. एंड जैसे ही आप कंप्लीट करेंगे समरी ऑन द बेसिस ऑफ हिस्ट्री, either examiner will tell you okay proceed for the examination part, or he might ask you कि डॉक्टर साहब based on your history taking, according to you what is this type of disease. So your answer will be कि sir my according to the history my diagnosis will be chronic otitis media squamous type according on based on history. He'll ask okay what are the points in history that suggest you it is Csom squamous. Okay, so can someone unmute and try this? I know repetition hai but
Foul
yeah, Dr.
smelling, scanty.
Yes, Doctor. Okay. So this as and when you'll keep on repeating these words, the same question will be asked. Why scanty? अच्छा, तो you will be ready with your answer कि sir squamous में scanty होता है, mucosal में ऐसा होता है. As you will say blood stain कि sir my discharge is blood stain, है ना? So the same questions will keep on repeating. These are all a set loop of question. Believe me, a person who gets these things into their head, it's a clean go ahead with for him. A person who gets confused, वो हर बार कंफ्यूज होगा कि यार why am I getting stuck every time. Okay, so till here I hope we are good to go till now, and we have around 20 minutes, so let's proceed to the examination part also. We'll see how long till we can go ahead, है ना? If anyone feels drowsy, please let me know, है ना? चलो let's go for the examination part. Sir, the patient is general physical examination. So the patient is conscious, cooperative, well oriented to time, place and person. वो bullshit बोलना है, ठीक है? Please speak those things. ठीक? Sir, patient is afebrile. This is the pulse of the patient. This is the BP of the patient. This is the respiratory rate of the patient. Sir, there is no pallor, icterus, cyanosis, क्लबिंग, पीडल इडिमा, लिम्फेडेनोपैथी, एवरीथिंग. यहाँ पे जो क्वेश्चन वाला है आई विल जस्ट लेट यू नो. वंस यू स्पीक अबाउट बीपी, प्लीज एक बार go around in the world, just see that you have BP apparatus somewhere. It should not be that you tell कि sir the BP is 120 by 80 mmHg, and if he asks you कि डॉक्टर साहब BP कैसे लिया, you are like oh वाला BP तो वो देखा नहीं मैंने, ऐसे ये किया. So this will not give a very good impression. If you don't have anything, just tell ki sir I would like to mention the BP also, but I couldn't find the BP cuff. Okay. So Dr. Sir, anything else? Why pallor is important? Anybody?
Role of lateral sinus thrombosis?
Yes, Dr. Sir. है ना? It is seen in LST. Anything else importance about pallor? One point you have killed. Yes, Dr. Chitra, I couldn't get you.
Nutritional deficiency.
Nutritional deficiency, very good. Because if the patient is having anemia, whatever treatment you are giving for the patient, whatever surgery you have planned for the patient, that might not be as rewarding as you would have thought about it because of this pallor wala thing. Okay, so this is the importance of pallor / fever from this place. Okay. After this, please mention about systemic examination. Unless and until examiner tells you ki move ahead. Otherwise, please mention your standard lines on CVS, S1, S2 normal, your standard lines on CNS, sir HMF normal, no sensory motor deficit, cranial nerve normal. ये अभी आखिरी में आएगा. When you will be discussing about the otoneurological examination, 7th nerve examination is a must for your examination. Don't jump ki sir all cranial nerves normal. Okay. CNS के बाद सेम फॉर दी पर एब्डो एंड फॉर दी रेस्पिरेटरी, ये बोल दिया. उसके बाद यू मूव टू योर लोकल एग्जामिनेशन. नॉर्मली व्हाट हैपेंस इज कि द पर्सन हु गोज फर्स्ट फॉर गिविंग द वाइवा, ही माइट फेस कि हाँ पूरा बताओ, बट जनरली एग्जामिनर गेट्स बोर्ड आफ्टर हाफ एन आवर 1 hour. ही विल बी लाइक ओके डॉक्टर साहब गो टू द लोकल एग्जामिनेशन. नोबडी इज इंटरेस्टेड इन ऑल दीज थिंग्स. ओके, if you as a resident are not interested after 3 years of residency, उनको 30 years हो गया, why will they be interested? Okay, so they will generally tell कि local examination में पहुंच जाओ. तो जैसे ही आप पहुंचते हैं local examination पे, अब there are a plethora of questions for the examination. Okay, after the this case I'll share 2 YouTube videos. Both are one is from one AOI conference and एक और similarly from the PG round clinics करके है, जानकी सर के साथ एक सर रहते हैं उनका है. Go through this. I've tried to accumulate maximum questions over here, but few will get skipped here and there. And second thing from my side, my suggestion will be whatever notes you would have prepared for CM's commerce, keep revising them. उसको छोड़ना नहीं है. Please keep revising them. Though the name is practical, 90% is theory. ठीक है, जो आपको सर्जरी नहीं करना उधर पे, just theory exam, theory questions देना है. And those 20 pages that I have shared with you guys, ratify it. Ratify मतलब ratify. उसको छोड़ना नहीं है. Please remember it. Okay, for the year examination, कि sir अब यहाँ पे whatever like my suggestion will be कि go as per you have been following in your own institution. Okay, many places they tell कि यार आप disease side को पहले examine करो. Few people tell the other way around. So my suggestion will be there might be a difference for that. So आप whatever you have been following in your institution, go ahead with that. Sir, preauricular region. Pinna, post-oral region, mastoid and EAC. अब यहाँ पे like whatever is there you can write normal, but be ready that what are the abnormalities that you are likely to see in the preauricular region. What are the abnormalities that you will see in pinna? Pinna में there is a very important question. What is the normal location of pinna? Okay, so please read those PDFs which have been shared. All these questions per section wise have like tried to sort out and keep it over there. आपको जो whatever extra questions that you find out, please put in them. That so it will be becoming handy for your revision. Okay, it won't be scattered कि आपका CM notes 5 registers में अलग अलग है. It will not come in handy. Okay, accumulate it at one place. What are the post-oral swellings that you are likely to encounter that you have mentioned? For mastoid, similar thing. Then the very common question is 3-point tenderness. Sorry. Then again, very common question. Then, sir, what are the things that you will be looking in the EAC? Can someone take a try? EAC में क्या देख रहे होंगे? क्या देखेंगे?
Discharge.
Yes, doctor. Discharge देखेंगे और anything else?
Erosion.
Yes, this is a very important part. This is a very important part. Deep canal wall erosion. Yes, doctor. So deep canal wall erosion is a very important part because it will guide you for your treatment purpose कि आपको canal wall reconstruction के लिए क्या करना है, canal wall down जाना है नहीं जाना है. So indication for canal wall down is this. One very important indication is this कि sir canal wall is already eroded, sir. Getting my point? So these are the things that will come as your question. Apart from that, lux abscess can be seen in the posterior meatal sagging can be seen in the wall of EAC, which is suggestive of lux abscess. Okay. Now after this, then you have to go for describing the tympanic membrane. The next which will be CM's commerce will revise again also. It's not, today I was thinking कि आज हम लोग सिर्फ history पढ़ेंगे. Examination we'll see in the next class. Okay, so in the next one what we'll do is we will place the image of this some autoendoscopy pictures and we'll see how to describe them. Okay, so for the tympanic membrane, my suggestion will be just tell examiner कि sir I am describing the right ear first or left ear first, whatever you are going ahead. This should not be confusion. Just don't jump upon the perforation. कि sir there is a perforation in the anterosuperior quadrant. ऐसे एकदम तुरंत jump नहीं करना. Okay, initially go with the normal findings. Normal findings क्या है? कि sir I am able to visualize this fold. I am able to visualize the handle of malleus. Okay, whatever you are able to visualize the normal things. Then go to the pars tensa, anything, either pars tensa or pars flaccida, anything. And then comment upon, like example, if you are like seeing retraction pocket in pars flaccida, you are seeing a retraction pocket. So just say, sir, there is I'm able to appreciate a retraction pocket at so and so location, and there is Sardis grade 2 retraction. Okay, so what will happen? The examiner will ask you, "Acha, doctor, what is the Sardis classification?" And here you are waiting with this most important question: TOS and Sade and Burko's grading for retraction of your pars flaccida and pars tensa. This is very important. One of the very important questions that you will encounter in your exam. Please remember it. Please learn it. Okay, if you have not any confusion, ठीक है? Believe me, it's a very confusing type of thing. It's not that कि आपको पता नहीं होगा. You definitely will be knowing it, but it is a thing which is confusing. Okay, so after that, you should comment upon if any perforation is there. Then similar things about perforation, similar things about retraction pocket. Where is the retraction pocket? How is it? Describe it. Okay, are you able to see any cholesteatoma in the retraction pocket? Okay, or any debris is present or not? Or are you able to see the fundus or not? All those things you have to comment. And like if you are able to visualize anything from the perforation, like middle ear में क्या आपको दिख रहा है? Is the middle ear mucosa inflamed? Or any extra things? Are you able to see the chorda tympani, if any, or any shadow of any structure, or the hypotympanic cells that you have to describe over here? Okay, so go in a schematic format so that you have at least 5-6 points to speak. It's just not perforation. ठीक है, सिर्फ perforation पर नहीं अटकना है. Then after describing the tympanic membrane, so Dr. Saab, what is the most sensitive test for hearing? Rennes or Weber? Weber. Yes, Dr. Saab. And why Rennes के लिए at least आपको जो अब देखिए Rennes हम लोग करते हैं. अभी one question is waiting for you. ठीक है. 256 512 1024. यहाँ पे you are ready कि sir please be very clear with the interpretation of Rennes and Weber's. I hope you will be all clear about it. Okay, so whatever it is, Rennes negative है, positive है, false Rennes, वो सब आपको पता होना चाहिए. The second question that they'll ask you is, अच्छा डॉक्टर साहब 256 negative है आपका. So what is the hearing loss that you are expecting?
Mild.
अरे नंबर कुछ बताओ ना. 5.
20 to नहीं.
हाँ अभी देखो we are just in a friendly discussion and we are getting the confusion. I'm not blaming anyone. I'm just telling you कि यहाँ पे confusion आता है ना. When you'll be sitting in front of the examiner hungry and under stress, you will definitely likely to make mistake. So today's one more task for you guys. Please make a table. ठीक है, 256 512 1024. Please mention what is the hearing loss, and then the examiner will ask you based on क्योंकि क्यों why I'm saying this कि अभी इसको like after finishing this examination during the summary again we will say sir the patient is having moderate conductive hearing loss and he will ask you why did you say moderate. यहाँ पे you will be ready with your answer. So that's why I've left this thing empty. Second thing will be your Weber. So Weber में as Dr. rightly said the Weber lateralizes at 5 to 7 decibels. ठीक है. Some places people say 5, some places people say 7. So I leave it at your discretion. As in our residency, we were told 7 decibel. Okay, and for 256 to become negative, at least 15 decibel should be present. Hearing loss of 15 decibel should be present. Therefore, Weber is more sensitive as compared to Rennes. This is a very important Viva question. Please remember it. Okay. इसके बाद आपका ABC आएगा. ABC को please लिखना है, not reduced. Okay. Then moving to the next part, don't forget the otoneurological examination. Don't forget the otoneurological examination. So what all things that you have to mention over here? Sir, fistula test is negative. And here is one of the very important Viva question. Here, what is this fistula test? So please answer this fistula test in 4 parts. What is the principle? Okay. How to perform it? And what is the inference? Okay. If you answer in this way, it gives a better impact on the examiner as you just directly jump upon the answer. Sir, we will alternatively press the triggers of the patient patient and we'll observe for nystagmus and giddiness. Okay, तीनों चीजें इसमें answer, your answer should be from this part. So you answer about the fistula test, you will answer about the cranial nerves, specifically for your 7th nerve and 8th nerve, whether they are affected or not. Then if you want to add for your gait, spontaneous nystagmus, rhombus or any cerebellar sign, this will complete your otoneurological part. And then please nose आपको बताना है. Nose में you will have to mention, sir, there is no external deformity, or if any, please mention no external deformity on anterior rhinoscopy. Whatever you are telling, you have to tell. This around lifting the tip of the nose, we see the columella is normal and the nasal vestibule is normal on both sides. And what is the septum? Septum mein if anything is present, whether there is DNS, you have to mention. Okay. And if you would have been told to examine the nasopharynx, like हम लोग को like as a resident we were like इन्हें nasopharynx भी बताना है, so we were mentioning about any mass present in the nasopharynx. So यहाँ पे करते थे. इसके अलावा same throat examination NAD करके आप छोड़ सकते हैं, and then you will land upon diagnosis. Now again take one more minute and just think in your mind what all points that you will put in diagnosis part. Just take 1 minute.
So degree of hearing loss भी mention करना पड़ेगा.
बिल्कुल. Okay, see what like should go about is, sir, the diagnosis is chronic otitis media, no short forms. ठीक है, no short form, squamous, right, left, whatever, ठीक, with moderate conductive hearing loss, without any impending complication. It's very unlikely that you will get a complication वाला case, very unlikely, है ना? So rest assured कि complication नहीं होगा उधर पे. So this should be the standard format. Chronic otitis media, squamous type with moderate, severe, whatever you are getting, conductive hearing loss without any impending complication. Okay, and believe me, what I'll speak next, many of you will not be able to believe. Okay, as a resident, first year में रहूँगा, I saw this Viva for the first time of the people going in front. So they were stuck with, sir, the answer is COM, squamous, and examiner जो थे, they were like helping them give 10 full form. And believe me, stress was a factor, obviously stress, है ना? They were stuck with the full form of COM that time. I know it's unbelievable that after 3 years of residency you will not answer that it's chronic otitis media. They would be knowing the answer, but that's what stress makes you feel and give wrong answers. Okay? So keep on practicing these questions. This will come, and if you are able to reach the diagnosis part, rest be assured कि आप pass हो गए उसमें. You have passed that thing. After the diagnosis comes the most important part. Let's take 5 more minutes and go through a few of the questions. How will you manage the case? If you come till this point, you have already cleared that. Okay? How will you manage the case? So, Doctor, can someone help me out? How will you manage the case? Very important Viva question. Anyone?
It's under microscope.
We will look under microscope. Very good, Doctor. Anyone else?
Culture swab of the discharge.
Yes, Doctor. Very good. Anyone else? Anything extra you want to add? कोई है मेरी तरीके वाला ऐसा रेसिडेंट मेरा होता तो सर सर्जरी कर देंगे. Anyone? No, don't speak कि सर्जरी करेंगे. Your answer for this thing will be, sir, I would like to evaluate the patient further. And how will you evaluate the patient further as you have... Haji Doctor Sahab?
Not on audiometry.
Yes, Doctor Sahab. So that's what that will be mentioning in the next slide. How will you manage this case? Sir, we will like to evaluate this patient further. So he will be asking you, how will you evaluate the patient further? So this is your first thing that you will evaluate. Sir, I would like to do a pure tone audiometry for the patient. So इसमें अगला क्वेश्चन आता है कि why would you like to do a PTA for the patient? So there are multiple things so that you can quantify the hearing loss that is there. Okay. For a surgical practice, before surgery, hearing loss should be available to you as a record basis. And third will be medical legal part. Okay. Or for all these things, you have to do a PTA for this patient. Second, as Doctor rightly said, you will do automicroscopy for confirmation of your finding, taking of culture swabs. Okay. And then, again, a plus minus question is there. This is what I like to go about. Sir, I would like to do a X-ray mastoid Schuller's view. Fourth will be HRCT temporal bone. Now, यहाँ पे examiner can catch you. Why? It's a दो-धारी तलवार. You say X-ray mastoid, and if the examiner says कि in today's world of 2026, why you will not go for HRCT temporal bone? Why you are just stuck upon X-ray mastoid? Sir, after that I was waiting for HRCT temporal bone only. Okay, because here the mix and match, the ideas of examiners are different. अगर आपने directly बोल दिया HRCT temporal bone करेंगे, he'll be like, okay, he's a poor patient, and why you want to advise an expensive thing for the patient and give so much radiation to the patient? So whatever he says, yes sir, okay sir, but this is the schedule, you should go ahead. Okay, don't mix and match the things. And last thing for today is whatever the examiner says, don't argue with the examiner. Okay, I have seen few people who are very bright, मतलब एकदम brightest of the residents ना, they know everything and multiple things they have read, and वहाँ पे they countered the examiner, है ना? So no examiner likes to be countered even if he's wrong, believe me. ठीक है? So if आपको 100% आप sure है कि मतलब ठीक है, he's entirely wrong, still please don't be Sunny Deol over there. ठीक है sir, okay sir, right sir करके खत्म करो, pass the exam. Okay, so this is the how will you manage the case के लिए आपको यहाँ तक पहुँचना जरूरी है. उसके बाद you will plan the surgery for the case. उसके अलग viva questions है. This you will see in a separate session. The entire surgery and what are the viva questions जो separately हैं वो एक session पूरा फिर से लेंगे. Okay, so please go through these things. जो video share I'll share 2 videos with you guys. Please go through it at 1.5x speed. So it will help you for revision also and framing something. It's not that everything is there. I have taken whatever I saw during my residency and post 5 years after that, and from the various lecture videos available elsewhere. Okay, so till now, here I'll rest my case for today. Okay, other viva parts for the management parts we'll take in a separate session. Any points from your side, please let me know. HRCT temporal bone, both videos, please go through at least twice, जो आपको share किया हुआ है. This will help in your building up of concepts. Still you have time. Last year the result of theory was declared on 15th of August. Okay, and today अभी we still have time, hopefully. ठीक है, and don't be surprised कि फिर से DNB 2-3 हफ्ते का time देगा practical के लिए, है ना? Last time it became a very big ziffy that people were of the purana mindset था कि after the result you will have 4 weeks, 6 weeks, 8 weeks of time. Last week it was only 2 weeks. ठीक है? So be ready to pull up क्या बोलते हैं ना, just to keep on packing up your things. So because अभी I know that अभी भी पढ़ाई नहीं हो रहा होगा, but still थोड़ा keep pushing yourself daily till the result comes, है ना? Once the result comes, everything will fall in place अपने आप से. Chalo, anything, anywhere you get stuck, please let me know. Okay, we'll meet again on Saturday. Until then, this week we'll dedicate to otology only. Okay, all the OSCEs will be from the otology section of your Scott Brown for this whole week. Second will be second thing will be for the otology from recent advances of Lalwani also. Okay, so for tomorrow, my suggestion will be please read only 2 chapters. One will be sudden sensory neural hearing loss second will be superior semicircular canal dehiscence syndrome. ठीक है, I'm just refraining myself. I know residency में it's very difficult to read, but ठीक है, दो chapter again you can revise. Tomorrow 9 o'clock we'll see around 10-15 OSCEs, 10-15 Viva questions total from these two chapters only. I'll try not to mix anything else from other chapters. ये दोनों chapters को please पढ़िएगा. If possible, be online at 9 o'clock. Answer it. It becomes fruitful for me also. कि like if someone is answering the question, if like I put that, I'll tell you the question also what I'll put. What DNB has asked, they'll give you a CT scan for a patient and give history of superior semicircular canal dehiscence syndrome, and the stat questions है SCCD के third window syndrome के कि what type of conductive, what type of hearing loss will be present. I'll ask you, if someone answers so it becomes interesting, it becomes both ways, है ना. अगर मैं अपनी तरफ से फॉरवर्ड करना है तो फिर वो तो ऑलरेडी सेव्ड है. I'll forward it in one go only. That doesn't serve the purpose at all. So if possible, keep on interacting. Otherwise, I know it's okay. Being a resident, all things are permitted. सब ठीक है. चलो, take care, have dinner, take care of yourself. See you again tomorrow 9 o'clock. Bye. Good night.